Dr. Keeley, for another complex case of diffuse calcific LAD, room 2 lab.
If you can see the slides, 74-year-old female, so hypertension, diabetes, because of diabetes, known diffuse 3-vessel disease, former smoker. Hemoglobin A1C, if you see, there was 8.3, LDL of 23 just on statin, and CRP less than 3. Serum creatinine okay today is 1.10 even today. So when she presented initially, presented because of exertional angina, on medication, and had a significant, MPI that was significant infralateral, as well as some kind of a TID which was seen. Good EF, and did have 3-vessel disease. So many of our intervention, prox-LAD intervention, some of our distal RCA intervention was all done outside hospital. So when she presented to us way back in March, she had proximal RCA lesion, just proximal RCA. All the other stents were patent. So with the syntax score that was reasonable, though she was 3-vessel disease, we proceeded with the PCI of the RCA. So this is where the RCA was. Like I said, we only did the proximal RCA. All the other stents were done outside, and looks like despite being diabetic, she responded well to the stenting therapy, and her prox-LAD stent is also okay. So circ, if you see, it's a small vessel, and distal circ is very small. You see some occlusion, but OM1 is, good. And this is VR, because this session is for diffuse disease of coronary arteries. Dr. Sharma kept saying that this one is crying, that one is crying. We can now tell him RCA is crying because we've not done a single RCA today. We only did a left system. So what do you think now? Again, calcium, right?
A lot of
I
calcium.
hope without imaging we can say, yeah.
Well, there is an interesting case because you have to work through a proximal stent. That is an interesting situation here. Any comments? Any comments from the panel? Dr. Mehta?
Definitely a 1-fiber. The question is rotatripsy or not.
All right, loud and clear. Anybody else? Dr. Duvuri, Dr. Fox?
Got to say, why not rotatripsy? So yes, 1-fiber, go carefully through the proximal stent, and then do the mid. And then
how would you wire this vessel?
Dr. Sharma here.
It's looking 1.5
1.5 looks like unanimous here. 1.5. Anybody else want anything else but 1.5?
Can you just show
How about orbital atherectomy?
Yeah, I think it's a reasonable. I mean, you certainly could do it. And to be honest with you, Anu was asking how you could wire it. Can you just show the angiogram so we can see how severe it is? Yeah, I mean, you could do it the conventional way with a workhorse wire, microcatheter, and swap out. But I actually think if you were going to go for one of those strategies, you could potentially primarily wire it with like a Viper or something like that too. So there are a variety of ways to do the case. But I think the length of the calcium, though, favors atherectomy. That's clear.
Yeah, for sure.
So this is the case, I think, where, like we were mentioning, could both OA or RA, both could be done. And, direct wire is okay, but only negative part, the direct wiring, if you see here, significant diffuse LAD disease. So if you go back, this is, we're trying to wire with the direct wire, we could not, then we have to go with Fielder fine cross, okay? And then if you see there, at that level, after that,
please move the hemodynamic window away from the current location.
the hemodynamic window.
Please move hemodynamic window away from the area where we're working and looking. All right, TV director, you listen to me. Move hemodynamic window away from where we're working and looking at.
Next year, we need one faculty to become a TV director. Yeah. Move the windows, tell them. We could not get the fine cross further down. So I think during our earlier case also, we learned that if your microcatheter did not make, you're able, could not get it further down, that's a teaching that you have to downgrade the bud. So we were all planning, like you all decided, go 1.5 bud. But once this happened, we had to downsize, and right now we have 1 to 5 bud.
George, exactly the kind of case you'll have to be careful with the long runs of the rotablator with hypotension there already.
Yeah, exactly. Exactly. Downsizing is very, you want the case to go smoothly. You don't want to have a prolonged runs here. It's very important. So the smaller burr at a higher even RPM would be beneficial here to finish the job as fast as possible. And let's see it live now. It's a very challenging case. You got to be able to go through the stent without interfering at least too much with the stent, and then go through. That would have been an advantage of the orbital atherectomy because you could just advance it easier through the original stent.
Any neosynephrine
Yeah,
here?
that's what I was going to say, George. I think it's very important that glide assist would actually allow you to take it down there. You might have to dynaglide this past the stent also. So that's the other attractive part of orbital.
You got to dynaglide.
You're set up really nice.
Is that the blood pressure?
Yeah, no neo?
Yeah, blood pressure
No,
is
hold on,
70
Is
and
that
dropping.
the blood pressure or is your, no? Yeah, this,
The zero may
your
be
pressure
off.
transducer, I think, fell down.
Yeah, that's a very, that's what it looked like when it drops that much and you didn't do anything. So
Yeah, we can use a
important
little
troubleshooting.
It's wrong,
neosynephrine
because
though.
other
Now,
thing is
would be
we
a bad
have
idea.
assist attached,
A
yeah.
little neosynephrine never hurts anyone during rotablator. That's
George,
great.
I think when you told them to move the hemodynamics, they moved everything in the room too.
right.
Yeah,
You were so forceful.
They got rid of the
they
transducer.
gave them to the outer space. I want to come back to the careful wiring. I can say there was a long calcific lesion, and right after the calcific lesion, at the end of the second most obstructive lesion, the vessel was a little tortuous, and there was a little bit of a tortuosity. So I think that's where they had trouble advancing the primary rota wire, and it was very, very important you don't create a dissection of that wire. And they're still working now in the pearl lesion. I'll try to use a laser pointer to help the audience a little bit. And there's another lesion further down here. That was a more critical
Yes.
lesion. So now, right now, approach the second lesion. I want to show it in this screen now. That's where the second lesion was, and the initial lesion was up here. So burr has gone through the first lesion, and now burring towards the second lesion as much as possible.
It's very
So
important.
second lesion also, George, look at it. You got to be careful. Almost looks like a calcium in the bridge. So
Yeah, that's right. It's exactly that. It's
very
a calcium
careful
and lipid
there.
bridge.
Yes.
Very careful, very careful.
yes, yes. So
That's
see
exactly that. It's exactly that the very little bit
yeah,
of a
you see that little
tortuosity
dip and coming back. Yes.
that had a little problem
And
with the
that's
wire.
another reason
Yeah.
when you have diffuse vessel and so distal, you probably go with a smaller burr.
And make
Would
sure
OA
it
be
doesn't
done?
jump.
Yes.
Very carefully. You see
Yes.
how she made sure that it didn't jump in distally. Came all the way back in order to roll the blade very
Run through
carefully
wire.
back down
We're
there.
going to do OCT now. Yep. So after this, we will do.
John, go ahead. Dr. Lasala has a
Imaging.
question. Go ahead.
No question. Just
Yes.
a comment on the outstanding technique is that you were careful going through it, but you didn't take too much time so that whatever pulverized material would potentially accumulating and interrupting flow in that distal high-grade lesion didn't have a chance to produce a prolonged no reflow state or slow flow state. You have to get through the outflow lesion so that you can continue to have better flow.
Yeah, what kind of RPM did you use for this rotablation? 150 or you went up to 165?
150.
That's great. Dr.
All-
Barman has a
so
question.
far-
Dr. Barman, quickly.
On the topic of that, I would, in these long diffuse lesions, give the pre-medicate through the microcatheter if you're using a microcatheter before starting the run with vasodilatorums. I think it was brought up in one of the early cases, but this is like the prototypical case for that.
Right, pre-medicate and adequate neosynephrine. You see the pressure is stable at 100. I'm sure they gave quite a bit of neo during the case from the nursing staff. That's great. Pressure
Yeah.
is 100
We'll,
over 50. That's great. It's pretty good level.
Yeah, you always
Okay,
notice-
you can see some STs there now. You see that?
Yeah, we give
Ready?
a little, again, the combination of nipride or nitro with
giving some
neosynephrine is very,
vasodilators.
very important for this situation. So we give both neo or nipride and help to no reflow and maintain the blood pressure. So giving
I'm
nothing.
giving some nitro, nipride.
Giving nothing
Then
because
flush.
the pressure is low, it's just not good because the
Yes.
STs continue to go up. So you got to give both.
Maybe you can give it through a
We should not
microcatheter
do-
over the rotowire.
Yes. Ready?
By the way, anybody has any question from the audience, come up to one of the microphones and ask your question. We'd like to take that.
LV function is normal. We can give fluid dose, IV
Yeah, of course, I'm sure
Yeah.
they're running fluid as well. You can see now with the neo things, with the nipride things are a little bit low, the blood pressure. I'm going to support it with neosynephrine, at least 200-300, I would say, right away,
Balloon.
in
Was
order
this-
to
was
go
the
up.
circ-
520 or 30.
The circ was small or down from the beginning? I didn't see the beginning.
Neosynephrine, please, 300 no neo.
I think the balloon
was a
is the
small
key
vessel.
here. Because you disrupted that long area of lesions, you have decent amount of disruption there.
Modification
And I would
vessels.
angioplasty this, the flow will become normal.
Yeah, you have that lucency
Yes.
there.
No, that was a question I was going to ask, and the case here is same. The plan was that after I do rota, I would do some kind of imaging. We have OCT catheter ready, but here with that EKG changes, little hypotension, slow flow, avoid imaging, quickly get a balloon ready, dilate it, get the flow back, and then we can decide.
Sounds good.
Anyone on the panel or otherwise
And what-
using IC epi for these types of cases, for the no reflow with the hypotension? Nobody? Nobody likes it?
Not epi.
No, anybody using ICM?
Occasionally, especially in
Usually
the
in,
acute MI.
in near code situation.
Not that much on
reflow,
IHR.
catheter, get it out into the aorta.
Down.
What size
This
balloon is
question
this? 275?
No reflow, there was a
2.5,
trial on epi.
and it looks like it expanded well.
One of my
Yeah.
colleagues use epi for these kind of things with a bad experience. We stay away from it. We just use nicardipine or verapamil, whatever you have in the lab, and then nipride sometimes.
With
through
Neo
the
as well,
microcatheter.
with Neo as well.
Especially over microcatheter, right?
I mean, my practice, I use Neo plus vasodilators, but for hypotension
Want to
with
do an
this,
OCT now?
there's some data showing it might be the
Go
way to
again.
go.
For AMI, it actually
So-
works beautifully.
Nice expansion. This is a 2.5. We went up to 22 atmospheres.
Yeah.
Okay. Let us see how the flow is. But EKG, you still see some ST elevation.
Yeah.
You may need
I'm going to give more
dilate distally.
vasodilators. Huh?
You may need to
I think she
dilate
started distally. She
Let's
did.
see.
Yeah, let's make a decision if we're happy or we need to go and give a nipride and nipride or in the distal bed. Let's.
Looks good, no?
Yeah.
The distal
Okay, let's
vessel
give
is
some vasodilators distally.
Distal
Agree.
vessel is
Give us
still
a twin
aching.
pass.
Can you get that wire a little more distal? Is there stenosis at the
No, it's
distal
in
part
the
of the wire?
apex.
Right at the transition point there, it
Looks pretty
a little
good.
Lucent, though, right? At the top of your wire.
Yeah,
A little
all
bit of
the,
time, the blood pressure should come up.
You have the file.
all the side branches are really good except for the apical one.
Pressure's coming up.
Your twin pass.
The
Give
ST should go
nitride.
down.
Side branches are good, right?
Yeah, just give it a
Yes.
little bit of time. It's looking good.
Yes. I'm taking a twin pass and then give some vasodilators. Nipride.
Sounds good.
You probably had some platelet
Verapamil.
activation from the burr.
How much Neo did you give the patient just now?
Right now, he gave 200.
And you have this patient,
Patient
doctor.
actually is on Brillianta with a PRU of 80.
Very good, well inhibited. Good planning.
Anu and George, a question for you. I mean, obviously, there was a distal lesion, so you might have favored the 1.25 this way. But are you, in our experience, we've definitely noticed less slow flow with orbital versus conventional rota. Is that something you all see too, or is this, more just anecdote?
I think more anecdote. I think we had this discussion also, Ajay, in the past when Rota Pro just came across. We all liked our conventional Rota. We were missing our
I know.
pedal. We were feeling like we were driving a car without gas. Yeah. I think we got used to this. This is, I don't know, somehow today you had 2 cases with slow flow.
Yeah.
It's rare. We see 1 or 2 a month with the amount of Rota cases we do. But this is exactly what I think people should know, that when you're doing rotational atherectomy of moderate to small vessel disease, diffuse disease, this is what you see, because it's the calcium burden, like all of you guys predicted, it has to go somewhere.
Terrific.
And in your bag, your Rota bag, do you have Rota Glide, but no vasodilators? Is that right?
No, we have. It has heparin 5000, all 5. 5 milligram of verapamil and 5 milligram of nitro.
Okay.
Then they will put the Rota Glide. If the patient is not allergic to eggs, and somehow they ask olive. They ask, they document that. Okay, we have given, you see the blood pressure is going down. We have given enough nipride.
Yeah, keep
EKG
going
improvement.
with the
You want
neosynephrine.
more?
Keep going.
You want more? You want more? I think we gave.
Keep going with neosynephrine.
We have given 300 mics of nipride. I think that's good. Nipride,
That's plenty.
little bit of nitro.
I think the flow is good. You need to see the
I think it's good
diagonal
enough
after the
now.
lesion.
Yes.
There's Dimitri flow.
Okay, now what I'm also going to do is,
I think it's all
The
right,
only
too.
one is the apical segment. Every other branch, including the major diagonals and the septals, are really good. So I would not be so much concerned, but proceed with the final treatment level.
Yeah, and the STs are better.
no, final treatment level, are we happy that is fully dilated? We proceed with stenting or you want imaging?
Now you can image.
I think we just put a stent and then we image afterwards.
Okay. Then
What's
looks
the
good,
difference?
right?
Because you got to image after the stent anyhow.
Ready? What was the stent? RC?
Going to do it.
Okay, beautiful.
You can see that as a poor man's assessment of ventricular function,
2.5, right?
most of that LED was not moving just
Yeah.
a few minutes ago.
We use
Now it
synergy?
This may be just the apex. Now it's much more
Or
vigorous.
synergy? Okay.
So this is,
Do you have
again,
two
not to
wires or
sound like
just
a
one?
broken record, but like, I would love to have a DCB to be able to use in that very distal thing and not have to stent the whole thing. Sad state of affairs.
Yes, you're right.
So how long the stent are you going to put? You going to put a 38?
48.
Or a 48?
48. You have a 48? Let's put a 2.5, 48 and synergy, and then we will just post that with the
248s.
proximal, right? Yeah, and then we'll do the OCT.
Okay.
See that septal, where the big septal?
So what I do-
No, there's a diag at the apex, then there's a septal. I will start from that level.
So let's go with the 2548, then you're going to do high pressure balloon, and then you're going to do an OCT and see what else we need to do. Excellent. Let's go. Let's hope it delivers. Make sure you remove the second wire before you stent.
And by the way, in these very diffuse disease cases, there's actually a reason not to do imaging because you can never figure out where to stop. And so sometimes you actually look at it angiographically, figure it out, and then image at the end.
Is that from Colombia, you're saying that?
No, I am. Last time Samin asked me to give a talk on when not to image, and
Yeah, but
you have
Ajay,
to-
that's making
you have to know
you
that.
feel good.
No, it's a clinical decision. It's a clinical decision, right? I mean, if you over-rely on the imaging, you're going to end up,
Okay.
you know.
I think that's exactly right. You got it. You got it exactly right. You got to cover the little tortuosity distally.
Yes.
You got to cover that a little more distally.
Go distal?
Yeah, you got to go a little bit distally.
A little more distal.
About 5 millimeters distal.
What's it? It was good right before.
Yes. Okay, we'll go distal. Okay,
Right about
now
the
time.
imaging now, there's no normal part of this vessel.
Yeah.
And a little bit more.
That's perfect.
That is a
That's
2
perfect.
cell.
We like
Yeah,
that.
that's good.
Perfect.
Okay.
We like that.
Okay.
3.0, high pressure, 20 proximally. Go.
Yeah, 3 or 20 for the proximal. Yeah, let's see. I mean, the tricky part is that we hope we not to create a distal dissection here with no matter what we do because we're already very distal in the vessel and we're not going to go into the apical and other segments with more disruption down here. Okay, so we're really watching down here. The proximal one, when I dilate with 3 O's, we don't have a problem.
Look at that.
Watch that guide.
Right. Yes, I know. It's like such bad disease
Now watch
everywhere.
the wire.
Wire is there.
Well, that's perfect.
Guide is down.
Before advancing the wire, just take a picture so we'll see better the distal vessel.
Okay, ready?
The wire is still back anyhow.
No, you wanted it there.
Yeah, terrific, amazing,
Yeah, very nice.
Beautiful.
amazing.
Okay, we are going to
nice.
post-dilate and OCT, okay? Then
Right,
we are
perfect.
done with the live case. This is the last case for the day.
And that's, we can see what Ajay was talking about, that, where do you stop? You do OCT, the whole vessel is diseased, wrapping around the apex, so,
The one reason, by the way, to do imaging in that segment is there are frequently bridges there. And what can happen is people can oversize the stent because they missed the bridge, and then that's where you have the issue. So, because of the sizing that she used, she avoided that problem without the use of imaging.
Yeah,
You don't want to put like a 3.0 or a 3.5 stent in that segment.
no, definitely not, because those can perf there.
Okay, ready with the OCT?
Yeah,
Okay.
ready to go city.
Any other questions regarding our technique or, okay, good, go. 30, 20, high pressure, yes.
For the audience,
We're
note.
bridging a little bit the new and the old stand. That's a good idea. And let's see if we can go one more length inside and do a little bit more.
Anu, when you say high pressure, what do you consider high pressure?
20.
20, 22.
With NC.
Okay,
Rarely,
I like
rarely
that.
24.
I
Yes.
like that.
But also notice for the audience, I mean, there's
A lot
no
of-
case here that's being done without post-dill. I mean, there's severe calcium. You got to do a really,
You
really
have
good
to
job.
post-dill every kid.
I think
And a lot of
maybe
people say high
you do
pressure is
maybe
16
you
atmosphere.
utilize a 275 in that middle segment because this balloon seems to be a little
There, she
banged
got
up.
it down.
Okay, good. Okay, good. But
Okay,
now,
one more here.
careful. So other thing we could have done is bring it back to the guide, rewrap the balloon and go further in. Yeah, good. Now here we are not going 20, 25. This is a 3-0,
Yeah.
okay, down. We are 18, down. And I'm not going to post-dilate the so-called where we thought is a bridge.
All right. So
Ready?
after this,
Coming up, OCT.
we'll do the OCT after this one.
Yes. And then we are,
All right. We have in about 6 minutes, we're going to go to the last session here, the conversations over complex cases with expert faculty. Get ready for the final session with great case presentations. We're going to have 6 in a row with expert faculty.
okay, we are ready for the OCT now.
We do OCT.
Sunglasses out.
We do
Why,
OCT.
why sunglasses?
The OCT image is super bright in this
In
room.
this room.
Oh, okay.
The rota is silent and the image is super bright.
Right. I mean, like, looking in the sun bright.
I think your body wire might help.
So that's funny. That's where you didn't post-dilate.
Yeah.
You may
And
need
that's
to
the-
put a 275 high pressure there.
Yeah. I think we may
2.5
want to
high
consider.
pressure.
Yeah.
Want to consider
No, no, I
doing
will
the
go not 275, 25.
275 15
275.
high pressure.
275 high
15
pressure. Yeah, if you can't cross, I'd definitely post-dilate it.
And,
It's a straight segment.
It's not,
mean, there's
that's where it dips into the myocardium, though, so you have to be a little bit careful.
Can you go back, Andrew?
The tip of your non-compliant balloons are always going to catch.
So we can see the setup of the OCT
Okay.
panel, by the way.
OCT.
The
But
new,
did you see what I did to get the catheter down?
Yeah.
No, we didn't.
Because it was more of a,
Dr. Kenny, it's a native.
let me quickly see. Hold
Just-
on, let me
just engage
do
the
it
guide.
after the OCT. Yes.
Just jumped.
Okay, ready?
Could you check the path?
No, the guy.
make
yeah,
sure the
there-
guide is in position. Yeah.
Yeah.
Are you going to do it or me?
I don't know if you're going to get a good image because it
I
looks
just
like
say-
there's stasis.
Yeah.
I do, Dr. Kenny.
No, hold on. He's asking.
He's asking what?
No, I don't see a distal.
Well,
I don't like this.
Okay clearance.
Huh?
Okay clearance.
Yeah, I don't.
Yeah,
I
he's
think
saying
you have
that's better.
stasis in the. Yeah, it's not great.
Yeah,
terrific.
I'm going to take it out.
Yeah, I think I would
Right?
dilate that mid segment.
Oh, sure.
Yeah.
Watch that it
No, you
doesn't.
know what? The distal vessel is so small.
2.5 only, I think.
2.5 high pressure
Yeah.
balloon.
2.5 high pressure.
Okay, give me, but we got the catheter down. So what I did was I pulled back the catheter to the dark portion where it is softer, and
Not
at
good
that
position.
area, then I got the OCT catheter further down. Even if I dilate, since the distal vessel is small, we may not have a good distal flush, in which case we should not be doing the OCT. Let's see. 2.5, right?
Yeah.
20.
2520.
This balloon may have trouble also to go. See?
Useful.
Yeah.
440.
Every time I use balloon,
Yeah, you got to get a fresh.
Yeah, you'll need a.
Yeah. Give us a 12 balloon, I guess. Okay, it may go now. Hold on, hold
You
on.
should be okay.
Okay, good. Okay,
There you
go.
go.
It's because you said, give me the other balloon.
Right.
That's why it went.
Terrific.
Okay, down.
How high was the atmosphere here?
18. 2.5 at 18.
Go to 20.
And you can see
go
that
up
the,
there.
Okay, they
Go
want
up
20.
there.
Go to 22.
Go.
and you can see that she
2.5,
spared
you go
the
higher.
very end of the stand, did not go to the edge of the stand, so you will not
Right.
disrupt the distal vessel.
The key is
Good.
right around that
down.
bend segment.
And do one more now in a little bit more proximal, half a length back, in order to probably exactly where this bend that the equipment wasn't going and all that. So got to do one more
Okay, go
right
up here.
before.
Bit still. Okay, we are 20.
That's good.
Okay, down.
When you pull
Try to
back,
do
that
proximal.
guy,
You got to really
that
disengage
guy's
the
going to
guide.
suck in
Yeah.
when you pull back.
Yes.
We need the guide in for the
Again.
OCT. That's good.
Yeah, watch the guide. There it
Yes,
goes.
I know that. It doesn't matter, right?
Yes,
Yeah,
do one
go
more
there,
here.
there.
There.
Perfect.
there. Do a good one there.
Terrific. 22 atmospheres here. Great.
22, 24.
Good. 24
Terrific.
here, down.
That looks good.
All right,
That
so
looks
let's
real
see
good.
if we can.
Now the OCT
If
will
the
go.
OCT still does not go, then
I think
We're out
the,
of luck. Then we conclude in the case.
Good man.
okay, I want to take a picture to make sure we haven't created anything by high pressure dilation in that area.
oh, it was a good idea.
Yes.
Yeah, that's a good idea.
I mean, EKG is good, blood pressure is good. EKG back to normal, right?
Yeah, EKG is normal. Excellent.
Okay.
Yeah, it
looks
looks better,
beautiful.
actually.
Terrific.
Looks
New
much
artery,
better.
new artery, yes.
Much better.
So maybe it was
This is going to look
Trio
great.
LED. Okay, now let us get the OCT back on.
The Prox LED is going to be the worst looking part.
All right, let's focus on the OCT now. Let's see how it goes, and we're ready to
Gonna go.
wrap up the last case of the conference. It was terrific.
It's okay.
Textbook case.
Okay, ready with the.
It's okay. Change the whole scene.
Closer, yes.
Okay.
Yep.
Yeah, see, now it goes
That
better.
went
That,
through.
that showed you had to do that post-dilatation.
Yeah.
All right.
You check the path.
Okay, now.
Let's see
Yeah.
how it clears.
How
Let's
are
see how
we?
it clears.
See,
Yeah,
much
great.
better. Much
Dr.
better.
Kini, I do.
Clearance?
Dr. Kini, I do.
Okay,
Like 1 second, enabling, vibrating. 1 second. Yeah, please, Cine, inject.
Fire.
inject.
Beautiful image. Thanks so much.
Is it still a sunshine there?
No,
No, it looks
great
really
image.
nice now.
It looks
Now it
better.
looks good.
Okay, so the right person has to do the OCT.
Uh-oh.
We did it right way. Means you have to really inject hard.
Yeah,
that.
after registration.
You so good see it?
Right? Let's see. Let's wait for the co-registration.
No,
Yes. So I should start from the distal, like small vessel. Yeah, distal.
This distal looks
perfect.
really
No
nice.
dissection.
Yeah.
Distal looks
Yes.
beautiful.
Very expanded.
That one
well
area.
expanded, come to the proximal edge.
Yeah, I see some calcium fracture behind the stent. That's why stent is well expanded.
Just go to that one area
Yeah.
where the MSA is.
Okay. Actually, the proximal edge is like with some fracture, but it's not a dissection, I think. It's because of the pre-dilatation.
Yeah.
I see some fractures here.
No, there's no stent there.
Yeah, no stent, but
stent.
nice fracture.
Yeah.
Oh God.
So-
It
No
looks like a
stent.
stent, right?
It's okay though.
There's no
That's fine.
stent there.
That's
Yeah.
fine. The lumen is good. There's no dissection.
Yeah.
But that's an example of a good fracture that you got without IVL.
Let's go to the MLD, please. Let's
Yeah,
study a little bit
actually,
of what's happening there in the MLD,
Yeah.
which is exactly.
AI said it's set at 2.0, but it's not true because
That's not
you
true.
see that this red line. So I can like modify.
Let's see.
Okay, yes, that's it. That's exactly where we were having the trouble, and is it?
Yeah.
Yeah,
We
it's there
cannot
is
say it's a
3.1,
bridge there.
but it's a diffuse region. And actually, this reference is like a 3.0. It's a more than 100%
Yeah, it looks great. It
expanded
looks
compared
great.
to the- yeah. It's an
Distal-
optimal result.
Distal edge
Yeah.
looks beautiful.
Yeah, beautiful.
Yeah, I wouldn't chase
It's a
that.
okay.
I
Favoring
think you've
vessel.
got a great result.
Anybody wants to do a 308 in that spot, or just leave it alone? Be happy.
No, leave it alone.
That is asking for perforation.
Yeah,
No.
it's perfect.
I agree.
Everybody's
No,
happy.
no, no.
Everybody's
Very
happy
nice.
the
I
way
think
it
we're
is.
all happy. Terrific case, Anu.
Terrific result. Terrific. Terrific result.